couple of minutes go by and make sure that we have a quorum. So I just want to let a couple of folks come in. We're really close to it. So, but I just want to make sure everybody knows that we are broadcasted live for the internet world to watch what we're doing. Okay, we're going to give it another minute. So it's 9 a.m. now. We've got, it looks like 8 members. We do need 12 to establish a quorum, but that doesn't mean that we can't meet with this group. We just won't be able to process the minutes from the last meeting of this meeting today if we don't reach a quorum. Okay, it's 9 a.m. and I am going to ask Leslie to take roll call so we can start this meeting. Let me go ahead and just so the public is aware, thank everybody for being here today. I want to go ahead and just pull up the membership so we have a list for everyone to know who is represented in this group. So Leslie, if you can, go ahead and call roll call.
Okay. Good morning, everybody. Angela Amar. Here. Ashur Lisek.
Thank you. Good morning, everyone.
Did I say that correctly?
You did. That was perfect. And it's been a while too. So that's
I've been practicing. Bill Welch.
Present.
Chris Bossy.
Please mark her absent excused. She won't be able to join us today, Leslie.
Okay. Elizabeth Bowhouse.
Same with Elizabeth.
Jennifer Wakeham.
Okay, I've been notified that Jennifer will attend today, so just please mark her present when she arrives.
Okay. Joan Hall. Jody Dominic. Joseph Greenway.
Here.
Karen Massey. Carla B. Ken Thorpe. Kyra Morgan.
Please mark her absent excused.
Lawrence Lerner. He had told me he was going to be attending, so I will mark him when he comes.
Okay, actually, he raised his hand, so
Oh, did he? Oh,
here.
okay, I can't see that.
Oh, you know what? Hold on. Let me promote him to a panelist. Okay.
So Dr. Lerner's here?
Dr. Lerner, I believe you are. Dr. Lerner, are you with us?
Okay.
He
Jennifer.
is, and I also see Miss Jennifer Wakeham is also with us.
Right. Okay. And we have Maya Holmes. Here. Mike Wilden. I believe he said that he didn't think that he was going to make it today. Phil Burrell. Shayla Holmes. Stacy Sasso?
And sorry, can you go ahead and call Miss Tiffany Tyler Gardner? I believe she's here. And
Tiffany Tyler Garner?
Present.
Okay. We had no Shayla Holmes, correct?
correct.
Stacy Sasso?
Here.
Okay. Todd Sklamberg? Tom Clark? Saw Tom earlier, so
Tom is here.
Tom McCoy.
I'm here. Sorry, it muted me.
Oh, that's okay. Tom McCoy, I believe he is absent and excused as well. And then we have Mr. Vance Farrow.
Hello.
Okay,
Great. And do we have a quorum?
hang on one. I do not believe so.
Okay, great. Well, I'm going to call this meeting to order, but we will go ahead and table the approval of the minutes of July 21st, 2021
11.
until our next meeting. And then I will close agenda item 1 and move into agenda item 2, and that's public comment. And so for those of us joining us online, if you can go ahead and raise your hand virtually if you would like to speak during public comment. If you are joining us on the phone, please raise your hand by pressing *9 at this moment. Okay, there's a couple of folks in the queue, but no one looks like they are indicating that they wish to speak during public comment. So I will close agenda item 2 and public comment at this time, and anybody who wishes to speak again will have a second opportunity later in this meeting. And then what I will do now is go ahead and open up agenda item 3, which is a continued discussion of the Peterson Milbank Program for Sustainable Healthcare Costs and Cost Growth Initiatives in our state. This is primarily going to be handled by Mr. Michael Baylett. What I would like to do is just take a moment to thank all of you for participating in this special meeting of the stakeholder group. It is a request made by me, as I indicated, to solicit your feedback as our governor considers issuing an executive order which will establish values and a set of year for a benchmark for our state. What Mr. Baylett will be doing is having a recap of the prior work and updates since our last meeting. We'll also go over cost growth, benchmark values, and a timeline in other states. And then we will host a discussion about benchmark values in Nevada and then kind of talk about next steps. So if there isn't any questions at this time, I really would like to give Mr. Baylett the maximum time allotted for this meeting, and I will turn it over to him. But let me just pause and see if anybody has any questions for me at this moment. I don't see any. So Michael, it's all yours.
Thank you. Good morning, everyone. Nice to be with you again. Let me set up my slideshow, which I'm having problems doing. There we go. Okay. So, as Sarah indicated, I'm going to begin by just recapping prior work. We haven't talked for a while, so I want to remind you of the origins of this work and provide you with some updates since the last meeting. And then the majority of our time will be spent talking about what a benchmark value or values should be for Nevada. I'm going to give you some context by sharing with you what the benchmark values look like in other states. So just for context, the Patient Protection Commission, which has been charged with making a recommendation for the benchmark program was created in statute a couple of years ago, and it's charged with making recommendations to the governor, the legislature, and the Department of Health and Human Services and other entities regarding quality, accessibility, and affordability of healthcare. Obviously, this work falls within affordability. The governor sent a letter to the commission in March and asked the commission to join Sarah in the participation in the Milbank, Peterson Milbank program for sustainable healthcare costs, which is supporting 5 states in developing cost growth benchmark programs. And the governor specifically asked for assistance in developing the cost growth benchmark, calculating and analyzing cost growth within the state, and analyzing drivers of healthcare cost growth. So more recently, the charge of the commission was modified by specifically naming the commission as the sole agency responsible for administering the Peterson Milbank program. And there were also some new responsibilities that were given to the commission, as you can see listed here as number 1 and number 2. We're not going to be talking about those today, but I just want to make note of the expanded responsibilities that were given to the Patient Protection Commission during the last legislative session. So that's the history of events. Now I want to give you a recap of what have been the commission's recommendations or preliminary recommendations to date.
And Michael, just for clarity, on the previous slide, it said it was Assembly Bill 328. Just want to make sure that folks know that was Assembly Bill 348.
Oh, 348. I'm sorry.
Yes. Yeah. And then
Thank you
if
for
I
that
can
correction.
just really quick interrupt, I'm sorry, but Dr. Lerner, it looks like you are in as an attendee, and I know we're having some technical difficulties, but I'm going to be promoting you to a panelist. So there's going to be a moment where your screen may freeze. So don't drop off, but I will be promoting you to panelist. And so sorry, folks, I just want to make sure that all of our participants can join us. Okay, that's it. Thanks, Michael.
Thanks, Sarah. So I'm going to review 4 slides that represent the preliminary recommendations of the commission with respect to the cost growth benchmark program. You will also see on some of these slides a recap of what you had to say in response. We have not yet shared that feedback with the commission because it hasn't met for a number of months, but we will do so. So first, starting with recommendations, they are recommending 2 definitions: total healthcare expenditures, which is the allowed amount of claim-based spending from payers to providers, plus all non-claims-based spending from payers to providers, plus all member cost sharing, or really cost sharing obligation, plus the net cost of private health insurance, which is defined as a private insurer's administrative expenses plus profit margin, or for a nonprofit contribution to reserves. The other definition that was recommended was total medical expenses, which is really a subset of total healthcare expenditures. It's total healthcare expenditures less the net cost of private health insurance, and it is reported net of pharmacy rebates. The PPC recommended that there be 6 sources of coverage that be included in the measurement of healthcare spending relative to the benchmark: Medicare, Medicaid, commercial, both fully and self-insured. And I will note those 3, Medicare, Medicaid, and commercial, represent the preponderance of spending in every state. But the commission also supported inclusion of the Veterans Health Administration spending in the state, state correctional health system spending, and Indian Health Service spending to the extent that that information is accessible. Those 6 categories have been included in other states as well, just as a reference point. You had some comments in reaction, and you can see them summarized here. And again, as I relayed earlier, your feedback will be presented to the commission when it reconvenes. Any questions or comments on this or the prior slide? I know I'm just recapping what we've talked about before, but again, we haven't met for a while, so I want to make sure that you remember this.
Sorry.
Okay.
Bill Welch has a question.
Okay.
Thank you, Sarah. Michael, remind me again, I apologize for going back, but as you indicated, it's been a while since we've met. And on number one, the total healthcare expenditures, I understand all of the categories, but in some respects, isn't reporting the cost of the health insurance premium going to duplicate some of the costs, because that premium is what is used to pay the claims, et cetera. So it seems like that is showing up twice, and maybe it needs to be, I don't have an issue with it being collected and represented, but I'm wondering if it should be as a separate category versus being all combined together.
Yeah, so thank you for your question, Bill. So the premium is not part of the equation here. This is looking at the spending that's being done with the premium, but not the premium.
Thank you for that clarification.
Sure. Yeah, no, I swim in this all the time, but you guys do not. And again, we haven't talked about it for a long time. So please feel free to ask any clarifying questions.
Another question, Michael, I apologize, is number 3. It seemed to me we talked a little bit about ERISAs the last time we met, and I noticed that it's not represented in the feedback from the advisory subcommittee, because I know that there's an interest in trying to collect the ERISA data, but it would have to be on a voluntary basis. The state regulatory process doesn't have authority over self-funded plans. Is that a fair statement, or was there no, or am I imagining that we had that conversation?
Well, Bill, your memory might be better than mine, which I will easily cede. I don't remember. It doesn't sound familiar to me, but we may well have talked about it. So in all of the other states, the states collect ERISA plan data because they're not collecting claim level data. They're collecting aggregate spending data. And so all the other states include ERISA spending, and I'll add the insurers report the ERISA spending, including all of the largest national insurers. So this has not been a point of disagreement or conflict in other states. There is a prohibition of the state requiring reporting of ERISA claim data. There's a Supreme Court decision on that, but in this case, the state would not be collecting claim level data, only aggregate spending.
Yeah.
And just for clarity, I think even on this slide, it looks like we will attempt to even voluntarily collect it, Bill. It says commercial, and you've got fully and self-insured indicated on there. So I believe the conversation was an attempt to make sure that they are also captured.
I see that now, sir. Thank you.
Yep.
Okay, thanks for your questions, Bill. And Sarah, if anyone else raises their hand and I don't see it, please just let me know. Okay, other recommendations from the commission. Number 4, spending should include state residents with both in and out of state providers, and also out of state residents with in-state providers. As I noted when we talked about this previously, there are no other states that include out of state residents. You all agree that out of state resident spending should not be included. So we'll bring that back to the commission when it reconvenes. And then last, and especially relevant for our conversation today, the commission recommended that the healthcare cost growth benchmark be tied in some manner to gross state product, which is a measure of the state's economy and its growth, and state median wage, which I think speaks to itself. You can see in the note here, there were a couple of members of the advisory committee who thought that the consumer price index, which is a measure of inflation, should be utilized because the state budget is linked to CPI. All right. Any questions about anything on this slide? So last, this is, I think, the last of the recaps, then we start moving forward. As of its last meeting, the Patient Protection Commission had not reached agreement on whether historical or forecasted values should be used of those two economic indicators that were of interest, that being gross state product and the median wage. You or a couple of you weighed in on this question. I'll note the second piece of feedback looking into whether Nevada's forecasted values available. We have looked into that and found that that state agencies are not do not have forecasted values available. Stacy, am I accurately summarizing that?
Yes.
Okay, thanks. All right, so so now I want to talk about our focus for today. As I've shared, the commission hasn't met for quite a while. That was because Assembly Bill 348 modified the structure of the commission, and so it essentially had to be renamed. And for this reason, there hasn't been a meeting since May. The governor, however, is still committed to the work that the commission's been doing, specifically around cost growth benchmark development. And so is preparing an executive order, as Sarah indicated, to establish a cost growth benchmark value. And so we today are seeking your input on what that value or those values should be. And this is in advance of the commission meeting again to talk about the same question. So we want to bring your input today to the commission when it reconvenes. So there will still be additional recommendations that will have to be developed specific to the cost growth benchmark that will follow the governor's executive order. We are discussing today just input on content that needs to be conveyed prior to the executive order. So these are the recommendations 1 and 2. What should be the benchmark value or values? And for how many years should the benchmark value or values be set? After the executive order is issued, we will need to talk about how to report performance against the benchmark. And there are a number of technical issues here that have a substantive impact on performance assessment. And so while technical, they're very important. And we will ask you and then the commission to weigh in on these questions. We also, after the executive order, will talk about how the state should leverage data through something that we refer to as a data use strategy to identify what's driving spending in the state and what's driving spending growth, and how to use that those analyses to inform the development of cost growth mitigation strategies. And then what should be the process for identifying and prioritizing those strategies. So all of that will follow the issuance of the executive order. Let me pause here because this is important and ask you for questions or feedback that you might have.
Michael, I don't see anybody raising their hand.
Okay. All right. So let's step into talking about values. So I'm going to share with you cost growth benchmark values from other states and also for how many years the states established their cost growth benchmarks. And then I'm going to ask you to advise what you think should be done in Nevada. All right, so these are all the states that have established values. Washington did so only about a week ago. So Washington is new to this table, and New Jersey is next, probably within the next month. So what you can see here is a couple things. One is in 5 of the 6 states, they establish multiple values that trend down from higher to lower. Rhode Island's the one exception, established 3.2% for 4 years, period. The other thing that you will note is that the duration of the values or the cost growth benchmarks also vary. So Rhode Island's is the shortest at 4 years. Oregon is the longest at a decade. The other states established their cost growth benchmarks, and well, I shouldn't say the other states, not all of them. Delaware, Connecticut, and Washington all established them for 5 years. And in Massachusetts, it was established for a longer period. So, somewhere between 4 and 10 years. Generally, states have started higher and then dropped down. In Oregon, it's just 2 steps. In Delaware, it's 4 steps. And so that's varied. And then finally, there is, of course, the values themselves. There are 2 states that started at 3.5 or above, Massachusetts and Delaware. The other states have started at 3.2 or 3.4. And you can see the benchmark values have trended down. The most recent states have gone down further than the earliest states. The 3 most recent states, Oregon, Connecticut, and Washington, have been between 2.8 and 3.0. I will note that New Jersey, which has not finalized theirs, goes even below 2.8, but they haven't finalized that yet. So any questions about the information that you are seeing on this slide or about how the states arrived at these values?
I have a question. I'm noticing for Massachusetts and for Oregon that they are choosing multiple time periods, like it looks like a 4-year time period versus, a Delaware or a Connecticut that's really looking at something through a 1-year time period. Could you just talk about maybe the reason why they're doing different time periods and some of the pros and cons to that?
Sure. Yeah. Well, some of the other states have 2-year periods. If you look, but those 2 states have the longest periods. So Massachusetts time period was set in legislation. They passed legislation in 2012, and the legislature said it will be 3.6% for 2013 to 2017, and then it may drop down to 3.1% if the state's Health Policy Commission so desires, and the Health Policy Commission did desire, so that's why it dropped down. In Oregon, this is this is part of the consensus building process. So they had a big split in their stakeholder body between the provider organization representatives and the consumer and employer representatives. And the way they negotiated it out was they were going to start at a value that frankly was higher than what the employers and consumers wanted. But their compromise was that for the second 5 years, it would be at a level that the consumers and employers wanted. So it's just, how the sausage gets made, so to speak. And that was their process. They were very consensus focused. That's not true in all the states, but in Oregon, they wanted to make sure that every single person in the room was comfortable with the recommendation. And that's what they had to do to get to yes. There are other states where they look for a preponderance of the group to agree on something, but in Oregon, they wanted everyone to be comfortable, and that's what they settled on. Other questions?
Michael, this is Bill. I know we're going to talk about in the next portion of the slide that we're looking at recommendations to make effective executive order as issued. But the benchmark, what time period are we establishing the benchmark off of? Because we've gone through, as we all know, some pretty curious times over the last 2 years, has created a lot of difficult challenges and obstacles that we've been trying to overcome for the last 2 years that are going to have long-standing impacts. And I know we're going to get into that here in next, but I guess I'm trying to understand how do we get to that benchmark that the baseline for which we're going to set this benchmark is, I guess, my question.
Sure.
So we're going to base it off of 2021, 2018, because that will drive a lot of the things that we need to consider under the next point that you're going to be raising, I believe.
Yeah, that's a great question, Bill. So obviously, this is the impact of COVID-19 on healthcare utilization and spending has been profound. And while there's been a big increase in spending related to treatment of people who contract COVID-19, frankly, the impact in terms of a reduction in people even accessing care has been even more profound. But regardless, it's distorted utilization and spending patterns. In my experience, all the states that have established these cost growth benchmarks have acknowledged that the trend rates for 2020 and 2021, at least, are going to be impacted by changes in utilization and spending patterns that are direct results of COVID-19. And so as a result, assessment of performance against the benchmark has to be viewed in light of that impact. But you'll know all these states created multi-year benchmarks. And so I think all the states are viewing this as a long play strategy. And if there are short time periods where there are going to be aberrant spending patterns, then they will interpret the information in that context. And then when we are post-pandemic, then we won't need to qualify the assessment in that light. I have not, though, directly answered your question about, so when would this be effective? I don't know this as a fact, but I'm guessing that if the governor is issuing an executive order soon, it's going to be to set the benchmark effective for 2022. And that means that the baseline spending would be obviously for a year prior to 2022. Generally speaking, the cost growth benchmark performance is reported year over year. So we would think it would be 2021 to 2022. We know that 2021 has been impacted by the pandemic. So probably that first year of performance assessment would have to be qualified by the impact of the pandemic.
And Michael, I think he alluded to this earlier too, and we'll get into the discussion after this, Bill, but the discussion of the value is one, but the measuring and reporting and performance against the benchmark are things that need to be discussed and worked out after an issuance of an executive order, which I think we'll get to what the issues that you're raising now.
Thank you. I appreciate that and understand your statement, Michael. The other thing that I hope, and I guess maybe it would be more appropriate in the next section of the conversation, but during this last legislative session, we had a significant pieces of legislation pass that have increased coverages for services that previously were not covered, particularly in the Medicaid arena. So that in itself will automatically increase spend by those new benefits being mandated.
Sure. Yeah. So Bill,
it would be reasonable that there would be some analysis to try to isolate the impact of that spending so that when we're interpreting the trend for Medicaid, we might try to isolate what was the contribution to trend of the new services. I think I might have shared maybe once before, but if not, I apologize. In Massachusetts one year, they had a big spike where they went above their cost growth benchmark. And it was the year that Sovaldi was introduced to the market. And so there was a huge increase in pharmacy spending for Sovaldi, but Sovaldi was literally curing hepatitis C. And so everyone agreed that it was just fine that the state exceeded the benchmark that reason because it was for a totally justifiable reason. So, all of the trend performance, Bill, has to be contextualized.
Yeah, this is Suzanne. If I could just add, maybe as a starting point on the new Medicaid services, I mean, we have done fiscal impact statements on how much we think those will add to the budget. Just as a one data point, just wanted to offer that. That was a part of the legislative process, and our fiscal team has put together, projections around the added costs related to new services.
Great.
Other things that I'm hearing from the majority leader in the Senate as it relates to 420, she's coming back to the state, the administrative branch, and maybe Suzanne would be familiar with some of these things. I actually heard a podcast yesterday where they were discussing some of the things that the majority leader is going to bring, some of which would be legislative actions in 23. Some of them would be things administratively that would help facilitate the expansion of those who require, not expansion, but help facilitate the enrollment of people who are in fact already eligible for Medicaid, as well as for subsidies on the insurance exchange. And so if those programs are successful, I haven't seen them yet. I only heard about them on the podcast yesterday, but those would be also things, and I'm assuming, Michael, those would be things that would be factored in as you just described a minute ago.
Yeah, as best we can, for sure.
And
Okay, any other questions?
I'm sorry, I have another question. Obviously things cost different amounts depending on insurance status, but wouldn't we still be capturing the spending of people who are uninsured in total healthcare expenditures?
So no, we wouldn't because we don't have a data source for doing so. This is a question that has arisen in other states as well. And there's often a desire to be able to include healthcare spending for people who are uninsured. And often hospitals will say, well, we want to share
with you our data, but the problem with that is actually nobody's paying for it unless they're paying for it out of pocket. And you have to capture the out of pocket. And the only providers who capture anything related to the uninsured tend to be hospitals and perhaps FQHCs. So because in some cases, there's actually no payment going to providers for the uninsured, we don't include it. And B, when there is an out-of-pocket payment, we don't have a means of gathering that data because it doesn't exist in some payer's repository.
That makes sense. I was thinking about the uncompensated care from hospitals, but I
Right.
agree with your data limitations on the other
Yeah,
side.
well, also, the measurement of healthcare spending is literally about money that goes from payers, including the out-of-pocket share for consumers and the allowed amount, to providers. It's not about the expenses incurred by providers.
and this is often a point of confusion, but we're not looking at
What providers are incurring for expenses. We're looking at what payments are made to them.
Helpful, thank you.
Ms. Tyler Garner?
Sorry, I just had a general clarifying question. This data set, is this a data set of comparable states or just states who actually have models in place?
so these aren't actually data. These aren't data sets. These are values that they
Set, and it's only for states that have cost growth benchmark programs
So these are the only 6 states
that have established benchmarks as of today.
Okay, thank you.
they all collect data from
Payers in order to assess performance against the benchmark.
and some of them have collected and reported performance. The first 3 states have done that: Massachusetts, Delaware,
Rhode Island, Oregon, and Connecticut literally just collected data for what they're calling a pre-benchmark period. So they are actually looking at what was spending growth 2018 to 2019 because they wanted to capture pre-COVID. and they will be reporting for the first time in the next few months. And Washington, like Nevada, is establishing its cost growth benchmark effective 1/1/22.
Right.
Michael, before we continue, I apologize. Our Nevada open meeting law is quite tricky, and our attorney has pinged me because we have established a quorum now. So if I can just pause for a moment and revisit agenda item 1 to request a review and discussion of last meeting's minutes. So if I can, I'd like to just open up a discussion for approval of those minutes. I do have to point out a couple of modifications for consideration of this group. Mr. Wilden, who is not here today, just wanted to have he made a couple of notes. And so members, if you can look at the minutes on page 2, there was in the discussion of slide 4 on the last paragraph, it indicated that the purpose of these conversations was to bring back decisions back to the PPC. That is actually should be stricken. It's actually going to be feedback. So instead of decisions, it should say feedback on page 2. And on page 3, the second sentence, we need to just clarify that according to Mike Wilden, Washoe and Clark County jails have very big spending. And so if we can consider those modifications, and then I would just open it up for any other discussions and accept a motion to approve. Does anybody have any other changes or modifications to last meeting's minutes? If not, can anyone make a motion to approve with the changes outlined that I just mentioned by Mr. Mike Wilden?
I move that we approve the meetings as corrected.
Right, do I have a second?
Yep.
Thank you, Ashore. Do I have anyone who's in opposition to that? Okay, nope. So it looks like that is approved unanimously. Thanks so much, you guys. And I will go ahead and close agenda item 1 and then reopen up agenda item 3 for Mr. Bailiff. Thank you, guys.
Okay, so if, by the way, if you can hold this information so that it's accessible to you in the document that went out to you before the meeting, it's just so you can look at them, that might be helpful. But take one last look. You can see range 2.8 to 3.8, 4 years to 10 years, often stepped, but not always. Okay, so previously, the commission and the advisory committee expressed interest in using indicators to calculate a benchmark value. And so we have created a few scenarios for you today. We started with gross state product and median wage because that's what the commission was interested in. We added a scenario with the consumer price index, the all urban or CPI-U version of it, which is the most common version of it. And did some modeling. So you can see here, we have, it says 3 scenarios, sorry, we added a 4th. And you can see the different weighting. So median wage, 80%, gross state product, 20%. All of these values use forecasted data, okay? So we could have done this with historical data, we use forecasted data. It's generally what the other states do, not 100% of the time though. So if we look at some range of median wage and gross state product, we come up with values between 2.4 and 3.2. And 2.4 would be lower than any of the other values in the other states. 3.2 is certainly in the range of a lot of other states. These values, again, just simply reflect what our forecasts for wage growth and state economic growth. Now, when we weight wages more highly, the rate is lower because the forecast is for slow wage growth in the state. But the forecast is for the economy to grow faster. This is not unusual. The economy has been growing faster across the country, and it speaks to the fact that a lot of the economic growth has been accruing to people at the higher end of the income scale. And when we use the median value, we get much lower growth.
And so when we flip the weights to 2080,
the value is higher because we are valuing state economic growth more than we are valuing wages. Then finally, the fourth scenario that we created here is an equal weighting of wage growth and inflation. Inflation tends to be lower than wage growth and lower than inflation and lower than economic growth. And that's why we get our lowest value here when we include CPI, which again was suggested by a couple of the members of the advisory committee when we talked about this previously. Any questions about the four scenarios that you see here and or about what we've done?
Mr. Burrell?
Hey, good morning, everybody. Michael, I was wondering if you can talk to us a little bit about your thoughts on these compared to other states. Like you said, number 3, median wage for at 20% kind of seems more in line with just so far what the data is from other states, but these other ones are a lot lower. So that's very concerning. Any thoughts? Do you think anything's of concern on your side, or what is your interpretation?
So I'll say first, there is no objectively right benchmark. And so when I share with you what the other states picked, it doesn't mean the other states did this right. It's just what they did. And I will say that there is
Some element of copycatitis across the states. They look at what those before them have done, and they tend not to stray too far from them, either at the high end or at the low end. Yes, these scenarios, except for number 3, are well, although there are some states that wind up near your number 2 and eventually, but scenario 1 and 4 are clearly below every other state. But if we go back to, so take a look at scenarios 2 and 3. So that's 2.8 and 3.2. 2.8 and 3.2 is where all of these states ended up, right? Somewhere between there. But what most of them did, except for Rhode Island, that said, we're just doing 3.2, that's it. They all introduced an add-on in their initial years. So, that is an option for you to recommend too. You could say, we want to wind up at a lower value, but for transitional purposes, we want to start at a higher value. I would say, especially for 2022, starting with a higher value would not be unreasonable, because if the governor is issuing an executive order, let's say sometime over the next month or so, and it's for 2022, that provides very little advance notice for payers or providers to make any changes in order to bring spending growth down.
Right.
Contracts for 2022 will have been negotiated for the most part by that time. So you could make an argument that it's reasonable to have the benchmark be a little higher for the first year, and then there'll be more advance notice for people to take action for 2023, assuming they feel a desire to do so. When you look at those values of 2.8 and 3.2, those are totally in line with the other states. It's the 2.4 and the 2.2 that are below where any others are. As I said, New Jersey right now is looking at a value that would end below 2.8.
and if you wanted to go below it, you certainly could. That's a very wordy, lengthy response. I hope it was helpful.
Oh, that was helpful. Thank you, Michael. I mean, I might have a couple more questions, but let me kind of
Yeah,
think
of
through what you
course.
said.
Ask as many as you want. So the questions for you all.
All is what
We've
should be
got
the
a-
value and for
Bill
how many
Welch.
years? And then why? Because when we present your feedback to the commission, we can't only say what you recommended, but we need to provide a rationale. I want to know, we are not asking you to reach consensus on this. You easily may not, you come with different perspectives. We will summarize your feedback. If you have a range of options, we will present the range. But we do want to be able to provide the rationale that you have for whatever you want to recommend.
Michael, this is Bill Welch. I'd like to just say that I agree with some of what you were just saying about the range and how it might be reasonable, like some of the other states, as I look back here, who raised the benchmark for the first year or two. I think for the reasons that have been highlighted earlier this morning in the conversations, with some of the things that happened during the legislative session, some of the things that may be transpiring through the administrative process as we move towards a public option, as we start to as we continue to respond to the COVID situation. I think if you put a benchmark in that's too low, that's not realistic to what the real environment is today, you're going to find that whatever the process is that a provider or a payer has to go before, they're going to find themselves having a lot of people coming for an exception because of these factors if we're not careful. So my recommendation would be go along with setting it at the higher level and maybe even making it a little bit higher for that first year and then transitioning down over time.
Okay, so Bill, because you spoke and you began to give a recommendation, let me ask you to share what you want to propose the benchmark values, because I think you're talking about multiple values, should be and for how many years?
Sorry, Michael, your speaker fades in and out, but I think you're
I'm sorry. I want to ask you to provide your recommendation for what you
Think the benchmark value should be and for how many years?
Well, I would think that we would use number 3 if we're picking from the options that you laid out in your slide. I would recommend that we're using option 3, and that I would put an increase factor in there of at least a 4% above that because of the variables that we've been taught, that I have and others have mentioned this morning.
Okay, and for how many years, Bill?
For, I would say, the next 2 years.
All right, so you are recommending,
If I can translate this, 4.2% for 2 years, and then 3.2% for how many years?
2 years. I would say for 2 more years, that would get us to close to, I'm trying to think of the time frame, that would get us close to when the public option would be coming into play, and we could sit down and reevaluate at that point. Because I think the public option is scheduled for 2026.
okay, thank you. Right, 4.2 for 2 years, 3.2 for 2 years. I just want to say, with respect to these scenarios, there's nothing sacred about them. We just
Wanted to give you something to see. If you want to vary from these scenarios, you certainly can do so. In fact, Stacy can calculate different weightings if you're interested in doing that as well. But this was just intended to give you a range, and you're not bound to them.
I appreciate that clarification, Michael, and I'll talk with smarter people within the hospital community. If they have different perspectives, I will submit something in writing to Sarah.
Yeah, feel free to do so.
Thank you.
Yeah,
Great, thanks. Phil?
Thank you again. Quick question, and this probably already was identified or talked about before, and I apologize if I missed that. I see CPIU West here on item 4. Was there any additional conversation or evaluation with CPI for medical care?
we didn't pull it up. We didn't look at it. It's a little self-referencing. that you're trying to increase affordability of medical care, and you're including inflation for medical care. So it gets to be a little circular, but we could
Mhm.
include it. I don't know that we have it
readily available. Generally, CPI for medical care is higher than CPI because healthcare prices have been growing faster than all other prices. Stacy, you don't have that available, do you?
No, I don't.
Yeah. Okay. Sorry, Phil. We don't have it at our fingertips. We certainly could access it and look at a scenario with it, but we don't have it available today.
And Michael, for context, is any other state actually taken medical CPI into consideration?
So no state has used CPI in any form.
Right.
We have put it on the table with every state to think about, but no state has utilized CPI.
And just for context, do you know what other states, and I'm sorry to put you on the spot, what weighted value they put on the medium wage? Just because I think that, especially in Nevada, one of the primary focus for the governor is to address affordability and to look at what patients can actually afford, I think has a really high value in consideration. So just for context, what is the threshold in other states on their weighted economic indicators, particularly when it comes to the wage component?
Yeah. So I know what Connecticut is. Stacy, can you see if you can look up what Washington used? I just don't remember.
Yeah, I'll try to find it.
Okay, so Connecticut wound up doing 80% median wage, 20% GSP, which for Nevada would be 2.37 or 2.4% rounded. It was higher for them. And this was a negotiation within their advisory group. So their version of the PPC was a group of individuals that included any insurers or hospitals or medical groups. So it was what I call a protected group. And they came up with 80-20. Their state patient advocate actually wanted to be 90-10. When they went out to their stakeholders and asked for input, the hospitals wanted just the opposite. They wanted 20-80, or what you see here as number 3. But ultimately, the state adopted the scenario 1 here. Washington. Yeah, go ahead.
No, and I was just wondering, so their methodology seems to make sense when you're looking at affordability for individuals and what they can afford. So that makes sense to me. And I was just, I know that their resulting value was likely higher than our state, but that's just because our median wage is probably a lot less than theirs.
But well, it's really not so much about
the level the wage is at, but what the forecasted growth is. So,
okay.
So this 2.37 is lower than their 2.8 because the forecast for growth is slower than in Connecticut.
Got it. Thank you for that.
All right. So
Suzanne?
Stacy did great detective work. Washington did a blend of 70-30 median wage and gross state product. Their blend is a little strange. They use historical median wage and forecasted gross state product. So these numbers are all forecasted. They use a hybrid of historical and forecasted, but theirs was 70-30.
Got it.
So Phil, do you want to make
a recommendation in terms of what you think the value should be?
And sorry, Michael, I also had Suzanne too, who just wanted to chime in for a moment.
Oh, sorry. Thanks. So just wanted to add a couple of thoughts. I don't know that this is a recommendation, and we'll think about that too, but just wanted to say, I think the gradual, like at least a year or two step down makes sense kind of for the reasons you were saying, Michael. It takes time to change contracts and, put additional initiatives into place and get them implemented. But I did want to say on the idea of the public option being a reason for the threshold to be higher, I would push back on that just a little bit, because I think one of the overarching goals of the public option is to increase affordability, much like, the purposes of Peterson Millbank. And I think it was also noted that it wouldn't be implemented till 2026. So just wanted to put those things out there in terms of thinking about the percentage, between now and then. And also note that an actuarial study will be completed as part of the 1332 waiver process to more based on evidence, figure out, the impact of that on the overall healthcare landscape of the state. But just did want to note that the goal of that is to increase affordability, and that it won't be implemented till 2026. So.
Suzanne, do you think that the public option becoming effective in 2026 should influence the time period for setting the benchmarks?
I think soon. I think generally like a 5-year range is what I was thinking about anyway. I just wanted to flag that we're not going to see the impact of that in 22, 23, or 24.
And in 5 years, 5 years would include the first year of the public option, which would be 2026.
Yeah, it's going to be implemented as of January 1, 2026.
Okay, all right. So you like 5 years. So I'll extend you the same offer. Do you want to make a suggestion in terms of what the value should be for those 5 years?
I do like the step down, starting a little bit higher and moving down. Probably need to talk to our team. I know we got some data this morning that I haven't had a chance to fully digest, but I think probably somewhere in I think 4 might be too high, somewhere between, the 3.2 and 4%. But if we have an opportunity to come back after we've looked through this, some additional data that we just got this morning. I know that this isn't the end all be all of this conversation, but just wanted to throw out some, top of mind thoughts. And we do want to opine on this for sure. I just want to have a chance to talk to Phil and Ellen and the smarter math people on our team before I throw a number out there.
Right, thank you.
Thanks.
Who else would like to weigh in?
Miss Maya Holmes?
I think I can jump in with a recommendation from our perspective. And before I get started, I just want to say we're really appreciative of all the work that Sarah and Michael that you've done on this and to keep this process moving. We know it's really time sensitive, and so we appreciate that you're pushing this, helping to move this forward. And we do really think that the benchmark is critical to begin to address affordability and access to healthcare in the state, which are, as you stated, just core priorities of the governor and the Patient Protection Commission's mission. And we're really supportive of the governor's efforts on focusing on healthcare cost affordability and access. So our understanding of the goal of the benchmark, and as Suzanne stated, is really reduce healthcare cost growth and bring it in line with the overall state economy and people's pocketbooks. So we are really interested in a benchmark that is a blend of the median wage and the GSP. And it's very clear, we've seen these numbers that healthcare cost growth has been just outpacing overall economic growth and wages for decades, and it's just simply not sustainable for the state, for employers, for patients. And it was very shocking, I think, getting back to the issue of, what patients can afford in Nevada. It was, we know we have an affordability crisis, but it was really shocking to see those numbers that 48% of Nevadans say that healthcare costs are unaffordable. And so I think this work is just really critical to address that. In terms of a specific benchmark, I think we actually are very interested in supporting scenario 1, the 80-20 blend of the median wage and the GSP. I actually think that's in line with what other states are going and the direction that they're going of, trending down to lower numbers. And I think it's also, based on the modeling that you included in the presentation, it seems like it's appropriate for Nevada. It fits with our economic growth. It fits with our median wages. Also looking, I think we would be looking at a minimum of that 5 years would be appropriate. And I'm going to stray a little bit. I actually don't really see the need to have the step down. To me, it seems more straightforward just to have one number. It would be different if this was like a fixed cap and there were penalties, but there's not. This is simply a benchmark to be able to compare, look at our healthcare cost growth over time. And so it seems much more straightforward. And as you've noted, we can always, and we will always need to contextualize these numbers. Other states, it seems like, as the newer states are coming on, they're also starting at lower amounts, and they're also having to deal with these issues of contextualizing, these aberrant events that are happening in the economy and with public health. So that's going to be an ongoing issue. And the one last thing I just wanted to say on the numbers, that I think also the blend of the medium wage and the gross state product, that those are numbers. And I think this is an important issue. I think, Michael, you had mentioned maybe it was to the advisory committee or the PPC at one point, but these are also numbers that kind of need to be relatable to the general public, that they can understand our rationale and our, median wage and how the economy is going. Those are numbers that people can relate to and understand. So I think that's also an important measure.
Great. Thank you for your thoughtful sharing.
Thank you, Maya.
Others?
I don't see anybody else's hands raised. Oh, there's a Shore.
Happy to weigh into the mix. First off, thank you again for putting this together. I think this is a really important conversation, and being able to have data and numbers to look at is extremely helpful as we're making these decisions. I would first just say that I agree with the medium wage and GSP approach. I think, as far as what percentage weight to which, I don't have strong opinions on that today. That's something I can take back and toy with our membership a little bit, but certainly agree that those are important places to look because of the cost to the actual consumer. And something, I just hope that we keep in context in this is, unfortunately, sometimes what a consumer is paying for healthcare can grow at a different pace than the actual cost of healthcare. So I think that will be an important number to really keep an eye on as well. As far as, step down approach versus no step down approach, I think a step down approach seems appropriate. If you look back to the Affordable Care Act, when it first passed, there was this idea of pent up demand for healthcare because people were getting coverage for the first time and they were sick because they had been without coverage. I think that's something we could experience in Nevada as we cover more Nevadans. Also, because of COVID, a lot of voluntary procedures were canceled, and one of the phenomenons I've been watching, unfortunately, is, during the early stages of the pandemic, diagnoses for things like cancer were down. And, now that hospitals are opening back up and people are vaccinated and feel more comfortable coming, we're seeing that the effects of not going to the hospital for those normal appointments and seeing your doctor for the normal appointment. So I think there's definitely going to be that pent up demand post-COVID that we should account for as well.
Yeah, great point.
If this is Bill, if I could just add to that, I agree with the comments that was just made. What we're also seeing in the hospital world, and it's a reality, and whether this will change or not, I don't know, but our healthcare professional costs are growing exponentially. For example, we have a nursing shortage in the state. We rank second or we're either in last place or second to last place as far as licensed healthcare professionals. We're having to use registry staff. Our registry staff cost is more than doubled and it's going up, it's not going down. The mandate at the national level, and some of our hospitals and providers self-mandating vaccinated healthcare staff, their staff to be vaccinated, is driving staff out of the workplace and increasing the cost of the workforce. So these things I think are real. I don't think they're real. I know they're real, and they are going to be a factor. So I guess we either take it into consideration as we set the benchmark, or we set the benchmark at whatever level, and then understand that if we're going to ensure that we have access, that these are going to be variables that people are going to have to be coming in, and it's variables that they're going to have to come before the commission or whoever the authority is that's going to allow somebody to go above the benchmark, and just know that that's going to happen. So, we can either face reality and try to create a benchmark that's going to be reflective of what reality is, and get it towards the mission and goals that was defined by Maya, because I don't disagree with what she's saying. But I think we find ourselves in a pretty precarious position right now. And I'd hate to see something that would stifle the healthcare community from being able to respond in a timely way. They certainly will do whatever they need to do to respond, but creating additional steps and processes that we have to go through is only potentially going to create a challenge to access the care. So,
yeah, thank you, Bill. I mean, currently in the immediate term, which
I'll also describe as the short term, there are a bunch of things going on linked to the pandemic that are challenging. But if the commission is going to be establishing a benchmark for a 5-year time period, I think it makes sense for you and for the commission when it meets to think about these recommendations as a 5-year time period with a short near-term period that is clearly adverse.
And you were right, ultimately, there will have to be a decision. Do you set the initial benchmark higher and then explain what was going on due to the direct and indirect impacts of the pandemic? Or do you set it higher and build in
an adjustment for that, or do you set it lower and then contextualize performance if it exceeds it in the short term?
But again, I would think about this as a long-term
strategy, not as a right now there's a short-term labor shortage and all sorts of system stress due to COVID.
Yeah, and if I can just point out to and just emphasize the discussion about this in the long-term setting, right? When we're talking about the overall attempt to reduce healthcare costs in our state for patients and making it more accessible and affordable, this is a longer-term discussion. And some of the things that are being mentioned by Bill and others, I think are really appropriate to talk about how you're going to be reporting against the performance. And then having an honest conversation about the treatment of high cost outliers and, doing and making sure that you take into consideration those factors at that time. But really, the benchmark value, like Michael indicated, is really an attempt to establish a long-term plan for the state to address affordability.
Yeah, I don't know if there's someone before me. Should I? Okay, go. I want to make sure not to take too much time to make sure other folks can get in and add their thoughts. I think a little bit for me is also to try and incorporate in sort of the what's gone on over the last year or so, and for the next year. I'm not sure how we would even arrive at a number that would be appropriate. So to me, I guess it just makes more sense, as Bill and had stated that that those variables are always considered as part of the analysis when we're looking at the numbers. I'm just not sure how you would come up with a methodology to try and factor in, this range of, because it's also varied dramatically by providers and by health systems. Some providers, I mean, they've done incredible work, all of them, throughout this pandemic, but they've had very different experiences through the pandemic based on their financial health going into it, their patient mix, whatever, their patient acuity levels, anyways, it would just, to me, it would be very difficult to try and arrive at a number that would specifically address that. But thank you.
Yeah, good point.
Yeah, and I want to just also reemphasize that our discussion on the value, what that is. I know sometimes it seems hard to get to one point, but one of the things that I want to make sure that the governor is aware of as he's considering his issuance of an executive order and picking a value is really on what weighted economic indicators do you all think make sense for our state? And so instead of focusing on the resulting value, really the discussion about what economic indicators make the most sense. And so in the scenarios that we have here, it seems like there's a lot of discussion and emphasis on a combination of the median wage and GSP. So if folks have more recommendations to make, maybe not talking about a resulting value, but really also where is your thoughts on what makes the most sense for our state? Is it really the 80-20? Is it something more like Washington did for 70-30? And why do you think that that is a good recommendation and a good place for us to consider? So I would be really interested in hearing from everyone in this group what weighted economic indicators you think makes the most sense for our state to consider. Okay, I don't see anybody raising their hand. I'm sorry, I didn't mean to stop the conversation. Tom, I don't mean to put you on the spot, but if you're still with us, I'd be really interested in hearing some feedback from you.
All right, anybody else want to share responses to Sarah's question or to the two questions
On this slide 16.
your chance to weigh in?
Sarah, this is Phil, sorry. I was just gonna ask if there are metrics you guys are already thinking about, or maybe there's a menu of things that you can share with the group to start from. Maybe that'll help facilitate a little bit more. And we can weigh in with some additional thoughts.
Yeah, we don't have a straw model.
Phil, right now. We really were looking to all of you to share what you think is right. And we're not going to bring a straw model to the commission either. We're going to share the same information that we've shared with you, except we're also going to convey what we've heard from those of you who've provided a recommendation on values.
Again, there's no objective right answer. The big picture is we're trying to create a strategy that will establish an expectation for how fast healthcare spending growth should occur in the future, with an understanding that there will be public reporting and in that form accountability for hitting the benchmark. But anything in the ranges that you have seen on a prior slide, anything in that range is going to be below what historical spending is. And that's the goal. I mean, now some might argue that healthcare is already not affordable because the spending's too high, and that actually it should be getting less, not bigger. We're not being that bold here. We're just saying it shouldn't grow at a rate that is not affordable. And the definition of not affordable
That we're using is essentially some mix of wage growth and state economic growth.
And I'll also say, in the end, the difference of, a couple of hundredths of a percentage point probably won't make all that much difference. What's important is that you're setting values and establishing some visibility about performance. against those values. Anybody else want to lend a voice? Otherwise, we will wrap up and share what those of you who have made a recommendation have shared.
So I have a question, Sarah and Michael, kind of process wise and understanding, open meeting law. So maybe Julie can let us know too, but we do want to put forward a recommendation that informs this, but need a little bit more time. So can you walk us through what our options are related to that? Is it just at the full meeting, that's where we would need to do it? Or is there opportunity to provide additional feedback beyond today and a full PPC meeting?
Yeah,
I mean,
question.
we can make whatever work. I just wanted to know what our options are.
Yeah, Sarah, can you help with that?
Yeah, so anybody who's watching now, and if you want to think about this and then share with me some of your individual feedback, I welcome it with open arms. And my hope is that we can have a commission meeting in the next few weeks that will then, what I will do is I will anticipate sharing any feedback that I have so the public is aware of what we have received before we share it with the governor. But what I will do, Suzanne, is go ahead and share it with me whenever you can, and we will make it publicly available to everybody. So everyone has an opportunity to review it, and then we'll kind of go from there. But the anticipation is to have another public meeting prior to an issuance of an executive order, so the commission can also weigh in.
Okay, that's really helpful. Thank you.
That's what is anticipated now. And so if that doesn't happen, I just still want to make sure that I still want to solicit everybody's feedback, and I will still make it publicly available. And I will, absent that scenario happening, I will still make it publicly available for folks on our website too.
Thank you, Sarah.
Stacy, did you have something? Yep.
Thanks. I just really quick, I wanted to say, I think that Maya really touched on how, at least from the Health Services Coalition groups that I represent, would feel. And I think it's important to just point out that the work of this committee is intended to keep affordability at the forefront. And at some point, our groups are looking at the cost of healthcare and the growth, and it's not going to continue to be sustainable. And so whatever we can do to, I think, keep a reasonable target number would be helpful. And then I also would look to maybe just my own preference would be to have one number over maybe like the 5-year term, instead of trying to start high and go low, or low and go high. I just feel like that becomes more confusing when, if you just have one standard number, it's easier to track and administer.
Well, and easier to convey to the public too.
Exactly.
Yeah, it is easier. All right, so Sarah, should we move to our next steps?
Yes, please.
So, as we've indicated,
The new PPC is going to meet in the next few weeks, we hope. And we're going to convey everything that you've shared at that time. And as we've said, the recommendations will then go to the governor, informed by your recommendations, and he'll issue an executive order. The PPC and this advisory subcommittee will continue to meet over the next few months. And we're going to ask you to provide recommendations on the 3 topics we've got listed here, maybe on some other things, but certainly on these 3. They are all substantive topics, and you will play an important role in providing input into the discussions. So, questions about anything here?
I don't see any questions. Nobody's hand is raised.
Okay.
Great. So Michael, I think that concludes agenda item 3. I just want to thank everybody for their time today and feedback and your continued engagement in this process and discussion. It's an incredibly important topic, and I sincerely appreciate your willingness to participate. And again, if you have any additional thoughts that you would like to share, please reach out to me and share them, or set aside for us to have a conversation. Now what I will do is go ahead and open up agenda item 4, which is public comment. So for those who wish to speak in public comment, if you are joining us online, please go ahead and raise your hand if you wish to speak. If you're joining us on the phone, please press *9 now to indicate you would like to speak. Okay, we have a few public participants, but none have wished to raise their hand to speak now. So I will go ahead and close public comment and open up agenda item 5, which is a wrap up and adjournment. So if there isn't any other questions that anybody has at this moment, I'll pause. Any members have a question, would like to discuss anything? No? Oh, Bill, there you are.
Thank you, Sarah. My only question is when will the announcement come out as to who have been appointed to the PPC?
I can tell you that I anticipate that announcement coming out soon. I know that the governor's office is just wrapping up their final decisions and appointment process. So I don't have a definitive date for you, Bill, but I think I can tell you soon. I anticipate it soon.
Thank you.
Any other questions? Okay, great. Well, thank you guys so much for your time today. I really appreciate it. My door is always open. If you have anything else that you'd like to discuss, if you think about it later, but if not, have a wonderful Friday and an even better weekend. Thanks so much, you guys.